Hola, en esta entrevista del Congreso Centenario tenemos a uno de los grandes invitados de la filial de Urología Funcional Femenina y Reconstructiva. Estamos con el doctor Sanjay Kulkarni, máster en ciencias, diplomado en urología, es miembro honorario del Real Colegio de Cirujanos de Inglaterra, fue presidente de la Sociedad Urológica de la India y de la Sociedad Internacional de Urología. Thanks, Professor, for being with us and joining us in this conference. We live in a world where the relationship between physicians and patients has changed. Our patients expect results that match with the surgeon's expectations, especially in the reconstructive area. Our patients require multiple surgeries or face complications related to the technique. How do you approach the preoperative counseling with our patients?
In our urology unit in India, we explain to the patient a consent, and we take every patient has a video consent like what we have today. We are discussing and it's being recorded. So I tell the patient, I'm Dr. Kulkarni, your name is ABC. You have this problem like stricture of the urethra. If your flow rate is poor, if you don't do anything, what will happen? If you do urethroplasty, what are the problems? We all also explain to the patient all the complications, and we tell them success rate of urethroplasty is around 85 to 90%. 5% patients may need a DVIU, and 5% patients may need second surgery. And that is explained and recorded with the patient in his own language. Because in India, we have multiple languages. And then only he signs the consent form. If I see about 10 patients, one patient may not be happy with the result. Unless we have explained to him beforehand, he is not going to give us a lot of trouble.
But in the surgery, the reconstructive surgery is characterized by surgical planning, but sometimes it requires modification based on the surgical findings. Can you offer an advice for the surgeons or the trainees in this field, how to open their minds, how to planify and be flexible to modify the original surgical plan? What do you do when you find that all the urethras are scars, there's no healthy urethra, but you need to do the surgery anyway?
Whenever we are doing surgery, many times we have to change the plan on the table. We explain to the patient beforehand. The surgeon will decide on the table what kind of surgery will be required. Suppose we want to plan some kind of surgery. Occasionally, we may need to do robotic surgery. And suppose I'm doing a buccal mucosa uretroplasty for the stricture. Occasionally, I may have to do ureterocalcicostomy, and very rarely, if the kidney function is poor, maybe nephrectomy. So that has to be explained beforehand, but we tell the patient it is the surgeon's choice on the table how to deal with the situation on that spot.
Is a way to think about what to do, or it's just training? You need a lot of cases, but you need to know more technique that you probably have done in your life. What do you think about that?
We have to discuss all the possible complications and how to deal with them on the table. All the alternatives are explained to the patient beforehand. But one has to be experienced in tackling any problem on the table.
I think right now we are living a revolution in the urethral structures with the cell-coated balloons, because sometimes some surgery that was reserved for the expert now could be managed by the general urologist. But we know that the balloon has some very few indications. The evidence is clear, but I have seen many uses of the balloon different from the uses that talk the literature. What do you think to go further, to do some offline procedures that if you think there's some logic, but there's not evidence?
I agree. Most of the urologists around the world are endourologists.
Yes.
They are not reconstructive urologists. Right. And they treat the patient initially with a stricture of the urethra. And many patients do not like to undergo urethroplasty immediately. So they would like to avoid surgery if possible. And then paclitax cell-coated balloon is one of an example where the current literature suggests that the 4 to 5 year dilatation-free success rate hovers around 70-75%. Now, apart from urethral stricture, it has been advocated to be used for enlarged prostate. Now, we get some patients of bladder neck stenosis following radical prostatectomy. So the indications of paclitax cell coated balloon will increase, maybe used one day for ureteric stricture. I don't know. So we have to keep on checking what is possible. It's all ultimately the patient decides what he wants, but we have to explain to them that there are some failures and how to cope up with failures. They may still need surgery after a few years.
You're a surgeon that have developed some surgical techniques. We all know about that. So that's why it's an honor to have you here. And currently, we have some considerations with the patient rights, because sometimes the technique is not approved. You have not enough evidence about doing. And also sometimes you have residents, trainees, fellows, and those are surgeons that don't have the full experience. Yeah. How do you talk with the patient about that? Because sometimes there's no technique that is perfect. You don't have the back of the evidence, or sometimes you don't have the trained surgeon for that. How do you talk with the patient? How do you face the patient's right in those conditions?
So the first principle of surgery is do no harm. We are doing whatever we want to do in the best interest of the patient. And how do I invent new operation? Very important question. We have a problem, complex problem.
Right.
We go to the books and read about it. Then we read journals.
Yes.
Then we go to YouTube, WhatsApp groups, watch videos. And then at the end of the day, you think, I'm the patient. Am I willing to undergo the same surgery? I will give an example. I always ask this question in a urology meeting. How many urologists undergo TRP? Rare. What about PCNL? Even rare. As a urologist, I do not want to undergo TRP or a PCNL. If I'm not willing to undergo this, I'm looking for alternatives. So we have to offer the same alternatives to the patient. And that's an advance, or that's an innovation, because this is the best for the patient. This is how we innovate new operations, thinking that I am the patient. Am I willing to undergo the same surgery? And many times the answer is no. So what we advocate to the patient, we are not willing to do on ourselves.
Finally, maybe one advice, final message for trainees, for fellows about the surgery, about the new times. What do you want to say to all the people, all the urologists interested in reconstructive surgery?
As I said, there are many subspecialties in urology, and then urethroplasty or genitourinary reconstructive surgery is a specialty which is progressing very fast. And the number of urologists performing only urethroplasty is very small in the world. So your work will be recognized around the world. You have a chance to innovate, because now new diseases are coming up, new techniques will be developed. Most of the advances in urology are due to engineering advances like a robot, paclitax cell coated balloon and other things, mini PSNL lasers. So now we are seeing more ureteric strictures following high-powered laser. So we have to do now more robotic buccal mucosa uretroplasty. So new surgeries will be invented. The best part of GORS, or genitourinary reconstructive surgeon, patients are usually young and fit. The success rate is reasonably good. And if it fails, then we have an alternative to treat the patient. Usually the patient does not die because of surgery. They're young and fit. So you can go to perform surgery, go home and sleep. If you do a lot of abdominal surgery, there is intestinal leak, urinary leak, distension, and sleepless night for the surgeon. That does not happen with reconstructive urology.
Thank you for joining us. It's a real honor to have you here.